Hello, my name is Myron Royce Mangalino. My presentation is on genetic testing for first-degree family history of breast cancer. A little background on why I chose this topic. About a year ago, my mom was diagnosed with breast cancer, and I just remember that this shattered all of our lives. And I just felt that this was such a relevant topic to research and find evidence based practices on because it really is a relevant thing in this time and age. So let's continue on with the presentation. Lung cancer is a leading cause of death in men and women. However, in women, except for skin cancer, breast cancer has been found to be the most common cancer in women in the United States. Women who have tested positive for BRCA1 and BRCA2 mutation have a higher chance of developing breast cancer in the future, especially between the ages of 25 to 30 years old, and this only continues to increase by the time they reach 30 years old. The childbearing years for women is 12 years old to 51 years old. So it's very important for these women to determine what they should do in regard to the risk factors that they have. In 2005, the U.S. Preventive Services Task Force initially recommended that women with strong familial history of breast cancer seek genetic testing or counseling. However, in 2014, this recommendation was updated to encourage these women to see their primary care providers instead and obtain referrals for genetic testing and or counseling. The standard for women to screen for breast cancer, according to the American Cancer Society, is that it should begin at 45 and continue annually until a woman reaches 54 years old, and then every 2 years until she reaches 74 years old. For women, if they choose to, because of risk factors or just because it's their choice, they may begin mammograms annually at 40 to 44 if they choose to. However, the U.S. Preventive Services Task Force recommends that high-risk women to begin mammogram screening every year at 40 years old. My PICOT question is, in female patients aged 18 to 40 years old with a parent with a history of breast cancer, how does obtaining genetic testing for BRCA1 and BRCA2 gene compared to simply following breast cancer prevention guidelines for breast self-examinations and mammograms affect their decision-making in regard to their quality of life during their childbearing years? Why is this important? Well, let's continue on to discuss the importance of this question. A review of literature was conducted from several databases, which included CINAHL, Cochrane, PubMed, and Medline Plus. The keywords used in this review of literature aided in finding relevant articles to support my PICOT question. The keywords used were as follows: breast cancer, BRCA1, BRCA2, genetic testing, genetic counseling, mastectomy, and mammogram. CINAHL provided an impressive amount of articles using keywords such as breast cancer and genetic counseling. When I grouped all keywords together using Boolean and or, I yielded a pretty impressive result of 264 articles. The Cochrane database did not produce as many articles as CINAHL did. However, that doesn't mean that the articles yielded were not relevant. When the keywords were grouped together, I yielded a result of 21 articles. PubMed produced 420,445 articles when I searched the keyword breast cancer. This was the most articles yielded in one search. This was a sign to me that I needed to refine my search a little better, so I grouped the keywords together and once again used Boolean and or, and I yielded 27 pertinent articles. The last database that I decided to use was Medline Plus, because its medical library is reported to be the world's largest and is part of the National Institute of Health. The refined search using all keywords with Boolean and or yielded 5 pertinent articles. Through this systematic review of literature, I was able to find 10 pertinent articles that answered and supported my PICOT question. The 10 keeper studies were then critically appraised in order to synthesize the published data that supported my PICOT question. Each study had approval from the Institutional Review Board or Research Ethics Committee. 8 of these studies were randomized controlled trials and utilized insurance plan samples, hospital and clinic samples, as well as previous randomized controlled trial results to conduct their research. The other 2 studies were meta-analysis studies. The intent of these studies were to determine the psychosocial aspect of risk-reducing surgery in females who tested positive for BRCA mutations after opting for genetic testing. These studies also evaluated breast cancer awareness in these females. One of the meta-analysis studies found that 51% of its participants chose prophylactic mastectomies after genetic testing, based on the influence of their primary care physician. This is important to note. Another study assessed females' knowledge of breast cancer and found that on a scale of 1 to 10, the participants scored a median score of 3 when it came to knowledge of breast cancer. And also, they found that less than 1/6 of these women knew any signs and symptoms of breast cancer. This is why education is key. Another study was conducted on Pinterest pins. In this day and age, people often turn to the internet when they have a question or have any concerns. This is why this study is relevant. The study found that 51.1% of the pins provided misinformation. That is a scary thought, because misinformation can often lead to negatively influencing a patient's decision making and can often cause doubt. Based on all of these articles, the most common answer is that a female who has direct family history of breast cancer usually opts for genetic testing, and if she is BRCA1 or BRCA2 positive, she opts for preventive surgery to ease her worries and improve her quality of life. Let us now discuss implementation and evaluation. The population I chose was primary care clinics. The change model that I chose was Rogers Innovation Diffusion Change Theory. This change theory was chosen because, due to the psychosocial aspect of this research topic, there is a high possibility that the desired outcome or change may be unsuccessful. However, through the utilization of Rogers' change theory, the researcher may resurrect the desired change at a more opportune or appropriate time. Rogers' change theory also helps in studying how innovations are adopted and understanding the spread of innovations between and within individuals and communities. The stages in Rogers' change theory are knowledge, persuasion, decision, implementation, and confirmation. You must first identify stakeholders during the implementation process. The stakeholders that I identified were primary care providers, medical assistants, insurance companies, and genetic clinics. Primary care providers are important because they are the vessel that will provide the education to the patients and will be the point of care for these individuals. Medical assistants are important because the providers depend on them to screen their patients and to inform them of which patients meet criteria for genetic testing referrals. Insurance companies determine if a patient is covered for genetic testing or counseling, and genetic clinics are important so the patient has options. They may also be found to be the best resource for the provider when it comes to evidence-based practice research, in-services, or current protocols. The first step is to educate stakeholders using evidence-based practice protocols on genetic testing. The second step involves all stakeholders determining the pros and cons of this change in practice. The third step, the stakeholders will then implement this change in their practices. The fourth step, stakeholders will determine effectiveness of this new process and how it can continue to improve. The fifth and final step, the stakeholders will confirm that this process is right for their practice. To determine that this process is right for their practice, we must discuss evaluation. So, a way to evaluate the effectiveness of this implementation process is to create a survey to evaluate if recommending genetic testing as a screening option for females who meet criteria has improved their decision-making and quality of life. You can designate a medical assistant to conduct these surveys and keep track of the data received. These surveys and data should be evaluated initially at 6 months and then annually. Another way to evaluate the effectiveness of this implementation is to collaborate with genetic clinics to determine patient compliance to referral appointments. In conclusion, many women are diagnosed with breast cancer daily, and the numbers continue to grow. It is important to know what your options are if you're considered high risk for developing breast cancer in the future, especially if you are of childbearing years between the ages 18 to 40 years old and have a parent who has been diagnosed with breast cancer. Being able to have access to the latest information, recommendations, and education is vital in making the proper decisions in order to lead a better quality of life. Through the use of genetic testing or counseling, on top of the recommended screenings for breast cancer, a high risk female may be able to make the proper decisions on risk reducing surgeries or treatments to have a higher chance in preventing cancer in the future.